Hi everyone. So today I'm gonna go over the antidepressant drugs as they are CNS penetrating drugs as well. I know it can be definitely a little confusing to classify all of the drugs, so I want to make this easy for you and this class of drugs isn't really too hard to get familiar with. I think it's more or less just memorizing the endings for each of the classes. So I remember when I talked about in the benzos, right? A part of those, like the benzos, barbiturates, the non-benzos, right? Buspirone, barbiturates like phenobarbital, or benzos like diazepine, right? Those were all used as anti-anxiety medications. And if you gave them in lower doses, like the benzos, they can be used for anxiety, but if you gave them in higher doses, they can be used for sedation. Antidepressives, or antidepressant drugs are also drugs that you can use for anxiety, so I want to just keep that in mind. But antidepressants are also used for depression. So we're going to see different classes of antidepressants that are used to treat depression, but also used to treat other types of anxiety related disorders, okay? So the first thing though I want to identify with you all is depression. So depression is a severe and long-lasting feeling of sadness lasting beyond the period of identified precipitating event. In other words, right, it's normal to be sad after something happens, right? But if that sadness persists for a month, let's just say, or months after the designated event, we're starting to see a problem, okay? And they're going into depression. Now, depression results from low norepinephrine levels, low serotonin levels, or both. And I want you to remember that because when we see some of these drug classes come up, they're actually going to work on some of these receptors. Symptoms of depression include lack of energy, sleep disturbances, abnormal eating patterns, feelings of despair, guilt, hopelessness, obsession with death, right? So we got to watch out for suicide, inability to concentrate or make decisions. So these patients cannot make decisions on their own. You must make or help make decisions with them because they cannot decide. So they should have very, very simple choices, okay? And they have lack of interest in personal appearance or even sex, okay? In order to diagnose someone with depression, they must have five of these symptoms that I just talked about for at least 2 weeks, okay? So if they had these symptoms going on for a month, they're definitely depressed. This is not just a temporary period of sadness. Nursing interventions generally, these become important because as I talk about these drugs, we're going to learn more about how interventions play a crucial part in treatment for these patients. So interventions when it comes to depression include monitoring their mental and emotional status, okay? Because they have obsessions with death, which means they might be suicidal, okay? They're very high risk patients for suicide. Monitor for underlying psychosis, okay? Are they having a psychiatric illness that is causing depression? Monitor their sleep-wake cycle. In other words, they might not sleep much, okay? Or they might sleep too much. Monitor their renal and GI status, right? We always want to make sure that how are they doing, right? Are they hydrating themselves? Are they going to the bathroom? We want to look at their liver functions and hematologic status. Okay, we want to know how they're doing. We want to make sure we ensure patient safety, monitor for vital signs, right? We always want to see are any changes going on in those from the baseline. Monitor for signs of dizziness, headache, tremors, nausea, vomiting. Monitor for anxiety, disorientation, agitation, diaphoresis, and fever, and monitor always their neurologic and cardiovascular status, okay? Those are just some typical interventions that we're looking at generally for depression, but also for these medications, okay? So this would be good to know as some things for Select All and Apply that you should pick if they're on these medications. Now, there's a lot of different antidepressants. So I'm going to talk about the main ones. So one of the most common ones is tricyclic antidepressants, or what we call TCAs. These block the reuptake of norepinephrine and serotonin. If we block the reuptake, that means we're blocking it from going into certain parts of the cells to be removed from the body, but we're actually keeping it in. Because remember, we said depression is caused by low levels of norepinephrine, serotonin, or both. So these block the reuptake of these hormones, therefore helping relieve the depression. Selective serotonin reuptake inhibitors, or SSRIs, block serotonin reuptake into the synapse. Same thing, but these specifically block serotonin, which increases serotonin levels. MAOIs are monoamine oxidase inhibitors. These basically are in the presynaptic terminal. We block these receptors, which increase catecholamines or norepinephrine, or serotonin in the synapse. Okay, so all of these work on very similar receptors because we're targeting the same thing. We want to treat depression. Now, for TCAs, the common endings are pramine, or like an inipramine or chlorampramine, trimipramine. Okay, they have this pramine ending. Another common ending, or another one that I've seen a lot, is an intriptyline. This one, that one's also a very commonly asked TCA. We also have serotonin uptake inhibitors, the SSRIs, which end in -tine. Okay, so fluoxetine, sertraline, paroxetine. They can also end in low-pram, so citalopram, escitalopram, things like that. MAOIs don't have an ending, but a very typical one is phenelzine. We also have isocarboxylase. I don't know how to say that, but that one right there. And we also have tranylcypromide. Okay, so these three drugs don't have the same ending, but they are classic examples of MAOIs. Now, another one that we're going to get into is there's some medications or some antidepressants that block their norepinephrine reuptake inhibitors, and that is phenylephrine and duloxetine, okay? But that one's not an SSRI, but these are just examples of other ones, okay? But the main ones are those TCAs, these SSRIs, and the MAOIs. Now, I want to get into the different types of antidepressants, starting with those tricyclic antidepressants that end in pramine, okay? So they block the reuptake, like I said, of norepinephrine and serotonin. So we can relieve depression. We help with sleep disorders, right? So we help with insomnia. It actually also helps with bedwetting, or we call that enuresis. So when children typically wet the bed a lot, or even as an adult, right? A scary dream makes you kind of go to the bathroom while you're sleeping. We can give this medication. We can also give it for chronic neurogenic pain, or like neuro-like pain, OCD, and anxiety. So these are also, like I said, I mentioned before, they are anxiety-like medications. So they can be used for anxiety and even OCD, because OCD is an anxiety-like disorder. But the main use of these is for depression, but it can be used for other things, okay? Now, looking at the adverse effects, most of them are pretty much anti-SLUD, right? So dry mouth, nausea, vomiting, constipation, urinary retention, blurred vision, mydriasis. Okay, we're seeing all of those anti-SLUD adverse effects, including orthostatic hypotension. Contraindications include any sorts of allergies, always pregnancy and lactation, no antidepressants for pregnant patients. And like I always say, rule of thumb, pregnancy is always a contraindication. Cardiovascular disease, okay? Also, if they have manic depression, not just depression, but manic depression, because mania is the opposite of depression. This is a type of person that is overly stimulated. They're super excited. They're very competitive. They'll fight with you. They're at risk for violence. They wear bizarre clothing, like, I don't know, really bright neon pants and really bright colored clothes and makeup that doesn't look appropriate, okay? So if they have this manic depression where they're cycling in between mania and depression, we don't want to give it to them. Now, the main point that I want you to know is, like I said, what we use TCAs for, their adverse effects, and as well as what sort of patient teaching should we tell them? One is that it's going to take 2 to 3 weeks for these antidepressants to actually make an effect. So we tell them it's not going to happen right away. Don't stop them if you feel like you're not feeling better after a couple of days, because it's going to take a week. Now, another thing is that a person is at risk for suicide as the depression lifts. So in other words, we want to tell the family members to watch out for them for any sort of behavioral changes, okay? Patients might start to say, or even to their family members, oh, you won't have to worry about me anymore. Soon everything will be easier. They might start getting their affairs in order, meaning maybe making wills, giving away prized possessions, even changes in appearance can indicate that they're at risk for suicide. So, as depression lifts, meaning once this medication starts kicking in, after 3 weeks, they are at high risk for suicide, okay? So we must put them on suicide precautions. That is a priority with these patients, okay? And these drugs can also cause, in a normal person, lethargy or confusion, drowsiness, and an increase in anxiety, okay? They are metabolized in the liver, so rule of thumb, contraindication, liver problems. All of the adverse effects are anti-SLUD, that's a very great mnemonic, and these are CNS depressant drugs, okay? So they work in that CNS. So because they're CNS acting drugs, we don't want to take other sorts of antidepressants with them, like MAOIs, okay? Because they do work in the CNS. So we don't want that. Other things include those GI antihistamine drugs like the cimetidine, ranitidine. We don't want those. SSRIs, no. And no oral anticoagulants like warfarin because they increase the risk of bleeding, okay? And that's why we don't want to give these. We also don't want to give sympathomimetics because remember, we're increasing norepinephrine and serotonin, which are sympathetic-like hormones. So if we're increasing those, we don't want to overstimulate them and give them more of that, okay? That's why these are CNS acting drugs, okay? So those benzos and all those, you really had to worry about CNS depression, whereas these act in the CNS, okay? So I just wanted to make this up. I know I said CNS depressants. They're not CNS depressants, but they work in the CNS, okay? So that's why we call them CNS drugs. But the benzos and the barbiturates that we talked about before were CNS depressants. I just wanted to apologize and clear the air because I felt like that was confusing. So nursing considerations for TCAs, like I said, be careful because they're at risk for suicide, okay? It's going to take a long time, 2 to 3 weeks to see an effect. It could even take as long as 4 to 8 weeks to even see an even more improvements in their mood, okay? So we're going to educate them and say, hey, at least 2 to 3 weeks for this medication to work. We want to administer, very important, this dose at bedtime. Why? Because of the risk of orthostatic hypotension. I mentioned that before, anti-SLUD, as well as orthostatic hypotension is a risk with these medications, okay? Never stop these drugs abruptly as they are life-threatening. These are lethal in overdose, okay? TCAs are very deadly. So we don't want them taking more than the prescribed medication and tell them that if you overdose or take too many, it can be lethal. It can be deadly, okay? We want to also tell them about comfort measures, right? Such as avoiding going to the bathroom before dosing and taking the drug with food because these drugs, like I said, they cause anti-SLUD, which is anti-going to the bathroom, and anti-digestion or bowel movements. So we want to take it with food to avoid GI upset and void before, just in case they have any issues going to the bathroom. And TCAs also lower the threshold for convulsions and toxicity, so we really have to be careful with patients that have seizures, okay? So as I said, all these drugs end in pramine. So these are some of the examples, but another commonly used one is an amitriptyline. So imipramine treats enuresis or bedwetting in children over the age of 6. The cipramine treats anxiety and sleep disturbances. Like I said, these are all TCAs. Clomipramine treats depression and early onset Alzheimer's, yeah. Amitriptyline treats depression. Doxepine treats depression. Nortriptyline treats depression in children. So the triptyline ending is common for TCAs and pramine is a common ending in TCAs. Monoamine oxidase inhibitors are another type of antidepressant, okay? These block MAO, which increase these catecholamines like norepinephrine and serotonin in the CNS. Like I said, these are CNS penetrating drugs. So these are more serious because they have more severe side effects and drug interactions, okay? Once again, these are also a type of drug that takes a long time to work. And it's irreversible, these drugs, okay? You can't do anything to treat it if these patients were to overdose, okay? Now, here's the thing. This drug is scary because you can't eat pretty much any sort of food with these drugs, okay? This is NCLEX question, it's most likely 100% going to be on your exam. You cannot eat foods that contain tyramine because they're going to increase the release of norepinephrine, which is going to be really bad. So, what are some foods with tyramine? Aged cheeses, cheddar, blue, Swiss, any sort of processed meat, right? Like sausage, salami, pepperoni, they can't eat that either. No chicken, no beef liver, okay? No brewer's yeast, so no wines, okay? No sherry or Chianti, I can't say that one, Burgundy, but different types of wine. No fava beans, okay? Um, Basically, you can't eat a lot of things, okay? So aged cheeses, cold cut meats like salami, pepperoni, sausage, no chicken, no wines, and no fava beans, okay? So pretty much you can't eat most things. You can't even eat yogurt because yogurt is fermented yeast and you can't have yeast extracts. And dairy products, no. So you're just seeing how many things they cannot eat with these medications, because specifically these mono and oxidase inhibitors, because of how likely it will cause that increase in norepinephrine, which is going to be really bad. So I'm not very good at saying these medication names, but it's isocarboxazid. This is one of those MAOIs. They're used, we don't really use these drugs, just before I get into that one, for first line for depression. This is more or less if they don't work to other antidepressants, we'll go for MAOIs. They're not the first drug of choice. We'll go to TCAs and SSRIs or any of those other ones before we go to these. So examples, like I said, what we use, the ones that are MAOIs, are isocarboxazid, phenelzine, trinicyclamine, or selagelene. Okay, so these are types of MAOI inhibitors. Okay, like I said, if they're unresponsive to other antidepressants, this is why we give MAOIs or monoamino oxidase inhibitors if they don't work with other antidepressants well. This is like a last resort drug. Okay, remember, no tyramine foods. They interact with every pretty much drug, so barbiturates, TCAs, antihistamines, CNS depressants, everything, okay? You can't even take these with over-the-counter cold medications. These also cause orthostatic hypotension, so we want to also tell them take it at night, things like that, okay? It can cause insomnia, agitation, sweating, and tremors, okay? It crosses the placenta, so we don't want to give it in pregnancy. Watch out for renal or hepatic impairment because we pee it out and all drugs are metabolized in the liver. And we also have to watch out for pheochromocytoma. I told you about that. It's a tumor, but it's a tumor in the pituitary glands, which causes an increase in those catecholamines. So if we're going to have increasing catecholamines and monoxidase inhibitors, they also increase catecholamines, no good. Prototype, phenelzine, as I said, these are antidepressants used as a last resort, but they can also be used for panic disorders. Same sorts of things, constipation, dry mouth, pretty much anti-SLUD, with orthostatic hypotension as well as tremors and dizziness and no foods containing tyramine, okay? Now, a really, really important patient education point is that it has a washout period of 2 to 3 weeks, okay? So you cannot start a new drug anytime soon. You have to wait 2 to 3 weeks before starting a new drug. The next thing is that if you abruptly discontinue this drug, you will have rebound hypertension and you can go into a hypertensive crisis. No good. Okay, so you must tell them, educate your patient, do not stop these medications abruptly. The next class of medications that we're talking about is SSRIs. These are also antidepressants. These are serotonin reuptake inhibitors. Okay, they're called SSRIs. They block the reuptake of serotonin. These are used for depression, OCD, panic disorder, generalized anxiety disorder, bulimia, and even PTSD. So, as I said, all of these antidepressants do have other uses and related to anxiety disorders, but they're mainly used for depression. Now, the problem with these is too much of these medications cause serotonin syndrome, so we really want to watch out for their vital signs. And you could think of SSS for sexual dysfunction, stomach cramps, or even seizures and spasms. That's signs of serotonin syndrome, not good, okay? So they could also have headache, dizziness, anxiety, and tremors. Those are signs because normally you wouldn't have side effects, but if they're showing these, they're having serotonin syndrome, really not good, okay? They don't have as much side effects as those TCAs. Discontinue in any children that have flu-like symptoms. It could cause children to become suicidal, so we want to watch their mental status. And these are first-line drugs for OCD. Like I said, these drugs end in teen. Examples are fluoxetine, sertraline, or even fluvoxamine, okay? Always contraindications, pregnancy, lactation, renal or hepatic impairment. And once again, all of these drugs, these antidepressants, we don't want to give it each other. So good tip for you to remember is that pretty much with any of these antidepressants, don't take them together. So no MAOIs, no TCAs when you're taking these SSRIs. Like I said, examples of SSRIs, fluoxetine, citalopram. Like I said, Lopram is another ending for those SSRIs. Duloxetine, acetopram, fluoxamine, paroxetine, sertraline. Okay? And they don't have as many adverse effects. Now, just to get into what some of these different drugs specifically do, citalopram does OCD and convulsions. Fluoxamine treats OCD and insomnia. Fluoxetine treats bulimia, OCD, fatigue. The half-life is 10 days, meaning it lasts a really long time. So we usually give this drug once a week because it's very active for a long time. And it's also given to patients who are fatigued and have childhood depression. Sertraline is used for panic disorders, PTSD, social phobia, OCD, and major depressive disorder, okay? Duloxetine is also used for major depression, neuropathic pain, and generalized anxiety disorder. Paroxetine is used for if you have difficulty sleeping or you're an insomniac, you have social phobia or OCD. Bupropion and mitropine have fewer side effects and they're pretty good. Bupropion is also called Wellbutrin, and they have fewer side effects, especially when it comes to sexual dysfunction. And citalopram is for childhood depression and OCD. But like I said, the rule of thumb, you might not need to know all of this on your exam, and that's okay too. But I just wanted to point out that all of these drugs are used for different things, these SSRIs, including depression, insomnia, and different types of anxiety disorders. But I would say knowing the class and what they're all generally used for, like I said, depression, OCD, panic disorder, GAD, bulimia, is a good place to start, okay? I don't think you need to know everything, but I'm telling this to you because you never know. If you see a question about one of these specific drugs, it's good to know which ones they're used for typically. Now, sertraline is like the prototype drug. Like I said, this is an SSRI, so commonly used for depression, OCD, social anxiety, PTSD, and premenstrual dysphoric disorder. These may increase suicidal thinking, so we have to watch out for mental status. And I said with all these antidepressants, rule of thumb, watch out for mental status changes. Okay, watch out for fatigue, headache, and dizziness because they work in the CNS. No pregnancy, once again, rule of thumb, no other antidepressants. We give in the morning or in the evening. No abrupt discontinuation because it can cause nausea, sweating, agitation, tremors, insomnia, or seizures, or serotonin syndrome, which can be very deadly, okay? So nursing considerations for these SSRIs, it takes 2 to 12 weeks to improve mood. So once again, it's going to take a long time for them to feel better taking these medications. SSRIs have little ability to block those dopamine, so that's okay. That's pretty good. Doesn't get too much into the CNS. And patients who don't respond to one SSRI may respond to another one. So you can try with different ones with these medications, okay? Then we have something called serotonin norepinephrine reuptake inhibitors, or SNRIs. These include duloxetine or Cymbalta and venlafaxine or Effexor. Okay, these inhibit serotonin and norepinephrine to elevate the mood. Okay, and this is a once-a-day medication. Now, nursing considerations generally for these medications and antidepressants in general include lower doses for the elderly, because remember, they have a weaker renal and hepatic function. Monitor for 4 weeks for a therapeutic effect, generally with all these antidepressants. Why? Because they take a little while to work, and that's what we want to tell them. It's not going to work right away. They're not going to feel better tomorrow after starting the medication today. Remember, suicide precautions are your priority, especially if these are used for severely depressed patients. Barrier contraceptives, because fetal abnormalities can occur if they're taking antidepressants and trying to become pregnant. Comfort measures, so most of these cause GI upset, so take these drugs with food. Make sure safety is your priority with these patients, and make sure we talk about education. We never want to abruptly stop any of these medications. Other antidepressants, like I said, bupropion, Wellbutrin, it's used for patients who want to undergo smoking cessation, okay? So just know that for bupropion, that it's used for patients who want to stop smoking but are also depressed. But we never want to give this drug for seizure patients or eating disorder patients, okay? And that's it.